My name is Ria Bright. I serve as a Senior Quality Improvement Advisor in the Office of Health Systems at USAID Washington. At this point, I would like our panelists for the first session to come and join me here on the stage. Thank you. So we know that countries continue to face ongoing challenges such as urbanization and expansion into animal habitats, including epidemiological and demographic shifts and growing income inequality. We know that climate change has added layers of stressors to the health system, where we've seen increases in the number and the intensity of extreme weather events. And we've also seen changes in rainfall patterns and shifts in disease patterns as well. We also must remember that some shocks are the result of extreme acts of violence or terrorism as well. Even without these additional challenges, it is difficult for the health system to have the capacity to provide basic health services. So how are countries dealing with health system shocks? Today we have a distinguished panel here with us, and I would like to take a moment to introduce each panelist to you. We have Dr. Sohail Saikat. Dr. Saikat is a program officer in the Quality Systems and Resilience Unit at the World Health Organization in Geneva. Thank you, Dr. Saikat. We also have Dr. Mayala. Dr. Mayala is a reproductive health and research health system strengthening specialist at the USAID office in the Democratic Republic of the Congo. Thank you for joining us, Dr. Mayala.
Thank you.
And we also have Mr. Oliver Wilcox. Mr. Wilcox is a deputy director in the Office of Countering Violent Extremism at the U.S. State Department here in Washington, D.C. We'd like to start off by proposing the first question to all three panelists. If you could provide your reflections on how does health system strengthening help to improve everyday performance so that systems are able to shift from a fragile health system to become a more resilient health system? So, Dr. Mayala, can we begin with you?
Yes, thank you. I'm really glad to be here. Thank you for the invitation. And I think everyone here is aware how and why all the pillars of the health system are contributing to make to provide performant outcome in the health systems. And I will be emphasizing on one of them, particularly the governance pillar, because USAID in the DRC is really involved in this particular pillar, even for USAID is working in the others pillar too. But governance is one of the cross-cutting, I can say, pillar to the 6 traditional defining pillar of the health system. And in the DRC, the Democratic Republic of Congo, the Minister of Health is currently implementing health reforms to make the system stronger and better coordinated. And one of the way they are doing that is to establish a decentralized system. That means that power is brought close to the populations and to make them more participating in the identification and the response of their needs. So in this contribution that USAID is participating, it's so important to mention that USAID is working at the central and provincial level. When we are talking about decentralization, we need to consider that we are the DRC in a huge country where previously the power is centralized at the level of the capital, and around now we need to make sure that all the level of the health system are contributing there. So USAID is working with other partners to a coordinating provincial team to make sure that all the resources that are fragmented could be used effectively to make synergy, and all the partners are responsible to deliver what is expected from them, and particularly in the provincial level. Thank you. We have the good experience from the provincial government that recently provided resources to support human resources working in the health sector. So that's something I think good to share with the team here. Thank you.
Thank you very much, Dr. Thank you very much, Dr. Mayala. Can I now turn to Sohel? Can you speak a little bit about how health system strengthening helps to improve everyday performance so that the systems are able to shift from fragile to become more resilient?
Thank you, Ria, and thank you, colleagues from USAID, and congratulations for organizing this event. And again, appreciation to Dr. Kelly, because we have a very, very sustained relationship between WHO and your department, and also thanks to the US government for continuing support to WHO. So I'd just like to simplify what Dr. Kelly was kindly emphasizing. I think the strengthening of health systems, there are basically 4 performance objectives that we wanted to see. One is in a very simplistic way, that the health services can be maintained at all contexts, quality services. Second one, same health systems to provide emergency-related services as we had seen during 2014-15 Ebola outbreak. The third one, I think if you recall the situations in the global organizations as well as in the member states, in many member states the emergency response, there is a vertical silo. Most of the time it belongs to the public health institutes, but there should be a central role of health systems to participate in national response to any public health event. So that is the third performance objectives we would like to see. The fourth one, I think the health systems to adapt with the changing demography, disease profile, and also the political context. I can recall what Dr. Kelly was emphasizing. So I think for routine performance of health systems, there has to be, that there is a 6 building blocks of health systems. So from a planning purpose, I think we can continue to maintain investment in those 6 building blocks. But one thing we needed to ensure is that the resilience aspect, the system aspects in building those 6 building blocks. Because otherwise we are creating another 6 vertical pillars within the health system, which is often the case. For example, surveillance is the term used by the colleagues in health security in the same ministry, but in the same ministry, people responsible for system, they talk about a district health information system or just health information system. So this is very important. The one aspect I would like to emphasize here, I think with regards to what Ria is trying to underscore here, is that a resilient health system doesn't automatically guarantee that health systems can absorb the shock. So across 6 building blocks, as well as we develop the system, we needed to embed the preparedness aspects for any form of public health emergencies. I mean, this is a fundamental requirement. As we had seen in many developed countries, a good health systems can collapse in the event of an emergency. So just one key point that I would like to highlight here. So the routine performance can develop the confidence in the health systems, can develop the rapport between the service provider, policymakers, and the communities that it aims to serve. So which can be a capital to call upon during an emergency. Over to you.
Thank you very much, Sohel. Can we turn to you, Oliver?
Sure. Thanks very much for including me today. I think that for the issue of countering violent extremism and for my response to this particular question and for my brief remarks later, please keep in mind that I'm looking at the intersection of the health system with a national security issue, and that is what drives radicalization and recruitment among certain segments of populations in certain countries into violent extremism or into terrorist groups. So I'm going to answer this broadly, and then when I get on to my remarks, I'll elaborate on it. But I think that strengthening the health system can help security and stability generally, and we've already heard a couple of references to the intersection of the health system and acts of terrorism or an environment where violent extremism is a local or national security threat. Number one, health strengthening or the strengthening the system obviously creates more of a state presence in remote areas. And to the extent that that state presence is ensuring access and equality and is consistent across districts or regions, whatever kind of political system you're dealing with. In some cases it's more centralized, in some cases it's more decentralized. People in one district know often what they're getting or not getting compared to their neighbors. And the example in that particular respect that I'm always struck by is the early sort of scatterplot of the presence or lack of presence of clinics. This was about 10 years ago in Yemen. And there was a very high correlation between northern governorates of Yemen where there were little or no clinics and local conflict or tribal unrest or Al-Qaeda trying to make inroads in particular areas. Of course, this was some time ago. Yemen is in a different place now, unfortunately. I would also say that by providing psychosocial services and capacities in places where radicalization and recruitment are issues, prisons, universities, and other locales. This is a key place where the health system and countering violent extremism intersect. And then I would just conclude, obviously, that when there are terrorist attacks, the health system is obviously implicated among other sort of first responders, and that is unfortunately in some places a very common occurrence. So I'll leave it at that.
Thank you very much, panelists. So just to tie back what each person has already stated, we've heard from Dr. Mayala here about the governance as being cross-cutting in the DRC and how the ministry is working to improve health reforms around a decentralized system. And then we've also heard Sohail talking about the fact that a resilient health system doesn't necessarily mean that the health system can absorb the shock. And that a good health system could potentially collapse under shocks, such as violent acts of extreme terrorism and things along those lines, and other shocks as well. And then we also, Sohail mentioned that, you know, as far as when it comes to a health system, when it's adapting, and it needs to keep in mind that it should be adapting to change to the demography and the disease profile. So those are some good shaping to the beginning of this discussion. So thank you very much. Sohail, I would like to turn to you now with this next question. From your global perspective working at the World Health Organization and providing support to member states, what are some of the challenges or barriers of creating sustainable systems, development programs that are flexible enough to absorb and recover from shocks? And if you could share some examples, that would be helpful as well.
Thank you, Ria. Thank you, colleagues. Let's take a simplistic perspective of the member states of WHO. I think we have some unofficial categorizations by looking at the state of health systems globally. So I think probably you could agree with that broad categorizations with me. So one category is countries without a functional health systems, almost collapsed. No foundations for providing the service, no foundations for tackling a public health event. So countries like South Sudan, Yemen, Syria, they are classical example, and also Central African Republic. So there are, you can see there are quite a good number of examples that there is no functional health systems. Then the second category, I think probably the bulk of the global countries fall into, is the countries has some level of functionality of health systems, but the institutions and the political infrastructure are very, very fragile, like Pakistan, Jordan. There are so many countries you can draw and you can put into that categorizations. The third one, countries we can consider that are matured health systems. Many countries in Europe, countries in North America could fall into this third category. So just trying to answer, I think, what Ria is underscoring here. So on category 3 and probably on category 2 and 1, some of the issues that we have are quite common. I think the colleagues here and also the WHO, we all have some level of a stake in those situations. I think the fragmentations, the vertical silo that we have between policy planning up to the service delivery levels. I think I can probably give some example. I mean, we interface with countries into a number of ways. I think the colleagues from emergencies, they interface on security aspects, on IHR implementations. Colleagues on system side, health system side, we interface on developing the health systems. At the same time, when the country is under a public health event or a humanitarian situation, then another set of actors from the same organizations we interface with. So just to give you some example, I think the perspective of example on the category 3, the countries which is a very matured health systems, I think the issue maybe we can recall the situations of South Korea, a country with a very, very sophisticated high-tech health systems with quality service provisions. In 2015, it has just one coronavirus index case traveled from Middle East, and the person went to one healthcare facility, private one, moved to another one, created multiple chain of communications. So the receiving healthcare facilities didn't have a shared platform to share the disease data between them. Once it was identified, we also involved from WHO side, although we did not have a country office in South Korea, we identified that the healthcare facilities is not just sharing the protocol. Even when we identified the public health event happening in South Korea, they are not following the protocol, the guidance from Korean CDC on contact tracing, on what should constitute as a close contact, and also in Korean culture, the family members are looking after the patients at the hospital. So there was a multiple chain of transmissions. So the key message that I would like to highlight here, Ria and colleagues, that a sophisticated health system can collapse if it is not properly configured for emergency preparedness. I think time is running short, but I got so many stories to tell you. It's from my own personal experience in Africa and many parts of the world. So in the second group, maybe I just give the example. You all know, I think Dr. Kelly also mentioned about Pakistan. 95% of public health capacity in Pakistan is centered around polio eradication. And it has got a completely separate budget line. It doesn't even report to Ministry of Health. Very, very effective, very successful. But the issue is that if it is not properly aligned to benefit the health systems, after this externally funded program comes to end, it could be a missed opportunity for a country like Pakistan. Now let me give, because time is short, colleagues, I think, so the third group of countries, those under fragility, in conflict, vulnerable, there are many examples. I think I had my esteemed colleague here from DRC, and I was personally involved in South Sudan. So the country is not functioning at all. There are 200 plus NGOs, they are all vertical. The authority and leadership of Ministry of Health is completely compromised. And as Dr. Kelly mentioned, the basic infrastructure like water and sanitation, even the electricity, even the water supply in the minister's office is absent. But at the same time, there is a billions of dollars going into that countries. I think time is up. Probably I need to find a time to speak to you, I think, over the tea break.
Thank you very much, Sohel. It's really helpful that you were able to provide some of those country examples to ground our understanding of resilience in health systems. I would like to take a moment now to turn to Dr. Mayala and go again back to a country example in the DRC, which is undergoing an active outbreak of Ebola. Even in the news this week, we're hearing reports from the Ministry of Health that the number of cases have now exceeded 1,000 cases and that the death toll is around 630 deaths. So, Dr. Mayala, from your experience in DRC, what are some of the challenges that the country is facing in the current Ebola outbreak, and how could a more resilient health system improve response efforts?
Thank you, Rhea. First of all, I want to remind that the current Ebola's outbreak is the 10th that the country is experiencing. The first one occurred in 1976. So there is about more than 40 years from the first outbreak. And the challenge, the most biggest we have right now, is related to the geographic location. The first one occurred in the remote rural area where mobility of population is reduced. Currently, the Ebola's outbreak is occurring in a large city where population is several times its movement, and with the risk of that the outbreak cross the border to go to the neighbor countries. And in second, I think something to mention is the concern about security. The Ebola's outbreak right now is occurring in insecure areas where we have several armed groups that involved there. And we also mentioned that in terms of preparedness, we need to be make sure that the neighbor provinces or countries are really prepared to face the outbreak in case of that this outbreak cross the border going to the neighbor countries. And the USAID is strongly working in building the capacity of the other actors that working in this specific area and in also the neighbor countries. I want to mention one thing important that occurring there in terms of community engagement. It's very important to have people to be engaged, population to be engaged, because they are participating in the surveillance system. They are the first to respond, to detect, to communicate the information when they identified some suspected cases. So it's important that this population should be empowered and create a kind of trusted relationship between the population and the medical authorities at different levels. At the end, I think it's so important to mention that in this large city where community or population are in movement and where health infrastructure is not really disseminated everywhere, we need to make sure that the population have good behavior in terms of self-burials to prevent the dissemination of the disease. This is, quickly said, the challenge we are facing there. In terms of how we can improve the response, in general speaking, I want to mention, as said in my previous intervention, the DRC is working in a context of decentralization. This is very, very important to emphasize, because where the outbreak is occurring is so far from the capital. So we need to make sure that resources are available where they need it. And in terms of financial resources, in terms of capacity building of the actors, and to make sure that the population are the first, I think so, responders to the crisis, and they have the capacity to identify, to alert, to contribute to the response in general. But we need to make sure that this intervention of the population is based of trust they need to have to the system and also to the authorities. That, globally speaking, what I can say about that.
Thank you very much, Dr. Mayala. And just to speak to your point a little bit about where you just mentioned the importance of establishing trust at different levels of the system, especially with the community. I know that when we're thinking about resilience programming, it's really important to consider the individuals and the communities that are also impacted by these shocks. So, Oliver, I would like to turn to you at this point and your work at the State Department. We know that the health sector has to respond to mental anguish, injuries, and death caused by any shock. But this is even more true when dealing with violent extremists and acts of terrorism. Can you please provide an overview of the State Department's programs in countering violent extremism and the importance of creating linkages with the health system? If you could also speak a little bit about some of the challenges that survivors and their families face and how the health system should be better equipped to respond to those needs. And then also, what are some of the health systems related challenges posed by the return of terrorist prisoners and foreign fighters and the implications for their families and the communities? Thank you, Oliver.
Sure. Well, I guess the good news is that in this emerging field of countering violent extremism and the much longer established fields of health and now this issue of health systems, that there, broadly speaking, is similar thinking and analysis about both the challenges and the responses. So I think we use the term resilience probably a lot more loosely than you all as health professionals or international health professionals do, but we view the resilience of potentially vulnerable or susceptible populations as a really key concept. And the whole line of prevention work in countering violent extremism really is focused on trying to build the resilience of individuals or populations where radicalization and recruitment may take place. So I think, as I alluded to earlier, health systems intersect with countering violent extremism across what we call the life cycle of radicalization and recruitment. And this starts much as the way you start your broader global health work with research and analysis. And we need to understand what we call the geography, the demography, and the drivers of radicalization and recruitment. It's not sufficient to look at the national level when it comes to this problem set. We have to look at the subnational, the regional, and particularly the local. And anecdotally, and according to some studies, what drives this problem in one neighborhood literally versus the one next door, there can be variations or differences. So sometimes our knowledge of the problem set has to be that granular. Demographically, it's not helpful when you have limited resources to say, well, youth between the ages of, let's say, 14 and 25, to take World Bank ages for youth, that's the target particularly in many of these countries where that population forms a majority of the national population. That kind of approach also, of course, if it's done publicly, has a securitizing and a stigmatizing effect. So we need to think about, within the geographic context, which particular cadres or cohorts of young men and unfortunately increasingly young women may be susceptible to radicalization. And then the last part is the drivers. The research tells us that poverty is not a driver of radicalization and recruitment, and this is really an important factor to keep in mind. And I would say that what we call the sort of psychosocial category of factors is probably the most common across cases of radicalization and recruitment. The research also tells us that this is a highly individualized phenomenon. So that's both a challenge because, of course, systems are supposed to operate at the level of collectivities, whether it's communities or sub-demographic groups or however you want to group people. But here we're talking about an individual level phenomenon despite the similarities. When it comes to prevention, I already mentioned building youth resilience is the main objective, the main challenge. And here really countering violent extremism where it's done well stands on the shoulders of existing youth prevention programming, again with its sort of psychosocial aspects or components, whether it is work dealing with gang recruitment or whether it is other kinds of positive youth development programming that is intended to empower youth or their families or their communities to get them away from quote-unquote risky behaviors. That is a key focus here. The systems challenge here is that countering violent extremism is dealing with a very specific problem set. And we do not have the mandate or the resources to come in and basically shore up an entire youth development system or set of programs in a particular community in order to be able to do this work. We come in with a very limited amount of funding, and we have to work with existing systems as we find them. So that is a challenge, and it's certainly by no means unique to CVE work. And you can see this in particular in prisons, where our job is not to fix the prison, the conditions, the overcrowding. We have to deal with those issues. We have to kind of take them as givens and sort of navigate around those particular aspects. The next area is what we call interventions. And if prevention work is done at the level of communities, collectivities, and is further upstream, interventions is clearly further downstream when it comes to countering radicalization. And that is trying to provide what we call off-ramps to individuals who may be on the path to radicalization or may be radicalized but have not yet committed crimes. Usually those are counterterrorism crimes, although some countries charge perpetrators with alternative crimes in order to get at the terrorism problem. And here, obviously, the work of psychologists and social workers is particularly key because when we talk about off-ramps, we're talking about off-ramping individuals into social service-based community arrangements. And this requires a multidisciplinary approach. So the psychologist or the social worker may be sort of the foundation, but the family, the faith worker, or excuse me, the faith leader, sometimes educators are involved in referring and counseling and supporting these individuals. And Here in particular, the challenge of securitization is really key. And we know from having talked with delegations of social workers and psychologists from a couple of countries in Asia that they deal with this problem, particularly in universities. You have one counselor for thousands and thousands of students. This is obviously a health system weakness in that particular context, and yet they might have 4 or 5 cases that they're dealing with of students that are radicalized or are on the path to radicalization. And these particular professionals don't know or may not trust reaching out to law enforcement. There may be problems with corruption and human rights abuses of law enforcement in that area or in that country. And so this challenge of securitizing what is essentially a public health problem is obviously foremost on the minds of these professionals in those contexts. So the off-ramp and the community-based intervention program offers those professionals the training, the capacity, the support, and links them with the other actors in the community to provide that service. Now, these intervention programs have been piloted in a number of Western European countries, so that obviously presents us with the traditional challenge of how do you adapt a rather high-end type of intervention, which is costly, to developing country contexts, where the field of social work in particular may be less developed, quite weak, or in some places even non-existent. And then finally, rehabilitation and reintegration, and this gets to the issue of homegrown terrorists who have served their prison sentence. It also gets to foreign terrorist fighters, and particularly their families. And to give you a sense of the scale of the problem, we're talking about tens of thousands of people returning or potentially returning from Syria and Iraq. What do the communities, the civil society organizations, and the government agencies responsible for these sectors do to respond to these folks? There's obviously here the issue also of stigma, and the stigma that these individuals will have to deal with, the stigma that their families will have to or do endure. And you see this in particular in some Lake Chad Basin communities where Boko Haram is active and where people return or the young girls or women that were kidnapped, and the Chibok incident from a few years ago was only one of several. And how do those girls, when they're released or when they're freed, and their families and their communities deal with this whole issue of stigma? And that obviously brings us back again to the psychosocial aspect. My time's up, so back to the chair.
Yes, thank you very much, Oliver. You raised several points that bring to mind the importance of linking health systems with other sectors, specifically the education sector in this example where you're talking about supporting youth to counter those acts of violent extremism. So thank you. So at this point, I want to transition over to Sohel. Sohel, I know at the World Health Organization you are working with other sectors, including the education sector, the environmental sector, agricultural sector, to address health systems issues. What are some additional opportunities that you would recommend for strengthening health system resilience, and how or why?
Maybe just a quick answer to what Ria, you're trying to indicate. I think most of the disease in the current century is coming from environmental or animal sector. So within the context of International Health Regulations 2005, again, thanks also goes to the United States on global health security agenda front, but we did manage to forge a strong connections with UN sector like Food and Agriculture Organizations, OIE, and WHO on a tripartite agreement. And so we are taking forward that joint collaborations at country level. So we are basically asking member states for participations of wider ministries in health systems development, so that things is forging ahead in most of the WHO member states now. But in terms of your main question, the additional resource, I think the scene that Dr. Kelly said, I think there is a lot of conceptual capital there that we can think about. But probably we can frame, I think, this additional resource into 3 scale. At national level, I think if you look at the low and middle income countries, now private sector is one of the major health care service provider. But if you look at the global health security agenda, the one that your country is championing globally, and also the international health regulations, even from my own personal experience, because although I'm part of the health system, but I provide interface with our WHO program, not only in headquarters, but through regional and country office. So the private sector is completely absent in health systems strengthening. The other most important one, which is happening now, I think I can probably give some example, this huge investment going in Africa as well as other continent from some of the rising economies in the East. For example, the Belt and Road Initiative. For example, just in Pakistan, the investment in infrastructure development is accounting to 62 billion. In Bangladesh is 38 billion. So there are so many big figures are going ahead in many countries. But the linking between trade, health systems and security is, as of now, is completely absent. So we needed to have a strong advocacy to proliferate benefits of those investment to develop at least the minimal requirement of health systems strengthening. I think maybe one of the recommendation, Director Dr. Kelly, that we can take from this meeting, whether we can think about what should constitute as a minimal requirement for health systems strengthening for provision of services as well as develop that security foundations. At the same time, I think this education sector one can be quite an effective one, given that some of these very basic health systems are strengthening, sanitations, hygienes, antimicrobial resistance, they should be part of our curriculum at school level. I don't know why it's not happening. The primary health care, some of these very basic health component should be the core foundations of our education systems in developing countries, so that we can see some organic development from very grassroots for children's educational and emotional development in those countries. I think at the regional level, the other thing is broadly absence. I think is also our connection, the communities in health. I think because we are probably not very good, I think, in finding our positions in many regional forums that we have. For example, SAARC, GCC, and the forum that we have in Southeast Asia. Some are very strong political forum that we have, the Commonwealth Secretariat. We can probably cluster the countries who are politically, religiously, socially homologous to develop some scale efficiency, for example, on laboratory diagnostics, on surveillance, on sharing of skills, and some of the soft resources that we can develop. I think that on the global level, I think we all have some level of responsibility to take, is that we are not doing very well, even within WHO, within our member states, within all those global donors, basically to develop that bridging between sectors responsible for health systems, between those of us responsible for global health security agenda, HR implementations, and those are the players within our same buildings, those who are supporting the member states on humanitarian and development side. I think the funding is going to remain tight within the donor. Funding is going to remain tight within our poor member states. But we needed to be very, very smart in 21st century, how we can harness our common resource and soft diplomacy to win the situation that are out there. Otherwise, we will have more Ebola, we will have more DRC, we will have more psychosocial impacts. So this bridging between economy, political aspects and the health sector, I think should need to be forced. And now, thank you.
Thank you very much, Sohel. So now I would like to turn to Dr. Mayala and go back again to the country-level perspective. Dr. Mayala, earlier you described some of the challenges of the Ebola outbreak in DRC. What are some of the initiatives by the government and even other development partners in country that are being implemented to create a more resilient health system? And can you also speak to whether or not those initiatives are linked with communities, the private sector, NGOs, and others?
Thank you. I want to say that and focus on some specific initiative that the Minister of Health is promoting at the different levels of the health system. As again mentioned previously, the DRC is engaged in a decentralization health reforms, and these reforms also concern all the sectors in the country. And I want to mention specifically that the Ministry of Health is really demanding of better coordination of actors, coordination of intervention. In terms of actors, we need to precise that these actors include the public, the private sector, and also the communities at the different levels of the system, both at the central, at the provincial, and also at the peripheral level. I think it's so important to emphasize that. And all these actors, specifically at the provincial level, are working together around a provincial plan and are engaged to fund specific budget lines to ensure that every line or intervention is covered and there is no gap to fill, and to have a better synergy and impact on the ground. And internally, what I would like also to mention something I think important in terms of how USAID is engaged in this different effort. Internally, USAID has a clear vision how we need or they need to provide our support to the country at this different level. We have an integrated approaches internally. That means that we bring together different offices within the mission, like health office, governance office, education, and also food and for peace, to have to participate in the process of the design integrated project to ensure that our different budget funding are covered specific part of the project, to ensure that in terms of implementation, we have our final or ultimate target that are the communities that consume our effort in terms of quality of basic services in education or in health. They have the capacity to demand quality of these services. I think it's very, very important to ensure that the community have aware of their power and have the voice to speak out and to make sure that when they are not satisfied with the quality of services, they can request and make demand. So USAID is working on this way to ensure that our projects are integrated, our projects are targeting specific need where different actors, again, public, private, are engaged with the communities. specifically in the Lualaba provinces. This is a province located in the southeastern of the Congo, where mining companies are working there. And in this specific province, we have the government that bring together all these actors to make sure that they're participating in the funding the provincial plan, and they fill out all the specific gap that could be exist. So I think that's good to know and to say and to share here, and I think USAID will continue to work on this way. Thank you.
Thank you very much, Dr. Mayala. All three panelists have raised some very important insights around opportunities for health systems strengthening programming to help systems to move towards more resilience. I think that it would be important now to take a break and open it up for questions to the audience so that we have a chance to hear from you. We have a microphone, and if you have a question or a comment or a country experience that you would also like to add and contribute to this discussion, we welcome those as well. Please state your name and affiliation, and if you could also mention the name of the panelist that you're directing your question to, that would also be helpful. Thank you.
Hi, everyone. I'm John Links. I'm from Johns Hopkins University. I predict that by the end of the day, the words system and systems will be the most used words by orders of magnitude in our discussion. And I want to, in a friendly way, be a bit provocative. When we say health system, I think we're focused on a pretty narrow definition of what we mean by that phrase as we routinely use it, and I think as you panelists used it. And particularly in the context of resilience, I want to challenge all of us to think more expansively about what we mean by the health system. And I'd just like to get your reaction to this thought. So I'm going to use a super extreme example. Think of any major disaster and the influx of external resources from not only other governments, but from citizens of other countries that are obviously utterly unavailable in the absence of a disaster. And I'm using disaster, you can use crisis, I don't care what term you use. And in that thinking, I would argue that in the context of our conversation today, the system has to be conceptualized way more expansively than when we're talking about what we mean by the health system in routine daily operation. Just like to get your reaction to that. Thank you.
Thank you very much. Oliver, would you like to start with that question?
Well, I think as I indicated at the outset, I'm somewhat different from my colleagues on the panel because I think I can legitimately deal with one particular slice, for the most part, of the health system, and again, that is the psychosocial aspects of it, as opposed to community-based health clinics or hospitals or other kind of aspects of the system. But I do take your point in terms of our work, and this gets back to comments that my colleagues made, that what is done in schools, and I would also stress, if you want to be even more expansive than schools, you have many contexts where youth are out of schools, either because of agricultural labor requirements or they are dropouts at age 14 or whatever it may be, and you have to think about how to reach youth, whether it's with health information or whether it's more focused resilience building when it comes to preemption or prevention of radicalization. how do you reach them in schools and how do you reach them out of schools? So I do take your point, but I think my colleagues can probably speak more broadly to the issue.
Okay. Sohail, you look like you're ready to.
I think we are just trying to be pragmatic here, but we respect what you are saying. We needed to start from somewhere. I think these health systems building blocks, I think, exist in a way within global player as well as within the member states. But there is admissions, I think, from both global and also national perspective that, for example, on Sendai framework or for IHR implementations, as well as for prevention of disease in 21st century, and also this concept of CVRN, we needed to go beyond the health sector to broaden the scope of the definition of system. I think we all know about it, but the reality is that we needed to, from a planning and from the realities, we needed to start by looking slightly more defined scoping of what should constitute as a system. Thank you.
Thank you, Sohail. Dr. Mayala?
Yes, I want to add some comment about this provocative question, saying that, as mentioned by my colleagues here, in the health sector, we need to be focused on some outcomes. That is very important to consider in terms of our ultimate targeted population coverage that receive quality and that afford the services they need to access. But there's something to not consider, that it's not in isolation, because to have a strong health system, we need to make the linkage with the other system, because considering the context in my country, when you are talking about access to the services, we need to think about, for example, the geographic access. That's very, very important. That is not depending on the health system alone. We need to have a good transportation system. We need to have a financial strong system. So health sector is not considered in isolated thing, but you need to put it in a global overall context. This is my additional comment. Thank you.
Thank you very much. We have a question. I'm sorry. We have one. Go ahead.
Hi, I'm Eric Sario with Save the Children. My questions are probably more for WHO and USAID, DRC, so Godfrey and Sohail. But just to say on the previous comment, at SAVE and in colleagues in our community, we tend to look at health system as systems for health, and we look at it as overlapping bounded systems and relationships. And so that probably wouldn't fit quite the reductive assumption. But the question I have for the panel, and thank you for the talk, it's very diverse, from perspective. But we're talking a little bit about health systems at multiple scales, multiple lens of analysis, but almost as kind of freestanding, and what makes them resilient or not. So you guys have been very comprehensive in addressing issues. But by and large, a lot of us, and we are, WHO, expert technical, reference point and technical assistance, USAID and projects. I mean, we work together, and we're a project mechanism. So to me, having looked at capacity sustainability for a few decades now, we still struggle with the differential between projects in their normal state, where we go and do stuff, and projects that try to be more capacity building oriented, health system strengthening oriented, more sustainability oriented. And with resilience, you're pushing the bar further. But what I would like to hear more about is the difference in choices and strategies that our technical assistance or intervention strategies, largely through projects, can have to influence the levers of resilience. And can we get there without getting through capacity, system strengthening, sustainability, or is it nonlinear?
Okay. Can we also take another question, and then we'll come to this? Thank you.
I guess the session, Igor Linkov, I'm with Army Engineer Research and Development Center. The session title, Shocks to the System. I have not heard much about shocks. I have heard much about systems and issues. So can you tell about how in your work you differentiate different shocks and stressors, acute, chronic, internal, external, and how it relates to resilience in kind of your line of work and thinking?
Okay. Dr. Mayala, would you like to respond?
Yeah, I want to, you're right with your question in terms of considering that we need to consider that talking about resilience, we need to think about or to consider that we have different context and situation regarding the country you are staying or working. For example, for my home country, the DRC, that has been experiencing a long time of wars and social distribution everywhere in the country. We cannot develop or design projects like if in other or developing country. This is why during my discussion with the colleagues here, I really mentioned the importance of working on the governance pillar. I think it's so much important to have because we still need in the stage of responding on the basic need. And we need to use something that could have impact on the overall system, speaking and considering that the governance, as said, is a kind of cross-cutting pillar because we have governance in the different pillar of the health system. So from my perspective, I think it's so important in this such fragile context, to build the environment that have the capacity to respond in terms of people have the capacity to have strategic plan, to know how they need to organize, to be structured, because we are still at this basic need. So that is different to consider a country like the US or another, maybe in the developed areas. So you're right, we need to be flexible and aware that when working in different contexts, we need to take into account that such context is in the fragile and in the progressive step to reach the resilience. That is the goal, because I cannot say that everyone can be proclaimed that they are resilient, because we are unexpected situation, a crisis that can arise, even here in such a developed country like the US. So we need to be flexible and to have this in mind when responding in different contexts. Thank you.
Thank you very much, Dr. Mayala. And then on to the second question about differentiating between different shocks. Oliver, would you like to take this one?
Sure. So I think for my issue area, obviously a terrorist attack is the principal type of shock, and the impact that has. And in that particular example, it's not just the psychosocial aspects, but obviously the local health system is implicated immediately, depending on the scale of the attack, the number of dead, the injured survivors, and so on. But what we're looking at also, a lot of what I outlined earlier, is trying to prevent essentially local shocks from ever occurring. So you can imagine if a foreign terrorist fighter returns home with his wife and son, we don't know if those individuals are radicalized still, or what their state is when they return home. And again, if they go back to their particular communities, what are the implications there for local, at a community level now, also at a national security level? What are the implications for security and stability in that particular community? And this is why what NGOs or state agencies do in the rehabilitation and reintegration space is important, because we have, again, a variety of situations where terrorists come home or they've served their time in jail and they may still be radicalized, they may be highly traumatized, and what are the implications, again, there for themselves, their families, and their communities. So that's not really shock on a big scale, but if you look at a community or a family, that's largely what we're dealing with.
Thank you very much, Oliver. And so to the same question, I know that you spoke earlier about the different categories that WHO has defined for countries as far as their functionality of the health system. Are there also categories for different types of shocks as well?
I think the way WHO is progressing with countries, I think is all hazards emergency preparedness, which is the underpinning requirement of International Health Regulation 2005, but we are also more increasingly focusing on the requirements of Sendai framework. So within WHO, we have a department, I think, on the mental health and substance abuse, and there's also a department on the physical injury. So there are some program in place, but one important development that we have now is this Global Program of Work number 13, this $3 billion target for WHO with member states, that 1 more billion people protected from emergencies, 1 more billion people will have access to health services, and 1 more billion people will have a better quality of life. So just addressing the question from the previous colleague is that, so we are also trying to work with the donor and member states to develop more predictable, streamlined support mechanisms. And there is an initiative, for example, to bring DFID. I think, presume there is also communications going on with USAID, JICA, as well as few other important donors, so that we can move away from project-based ad hoc support to more streamlined country capacity development. But I think WHO is also dependent on the support of the member states, but the program of work that we have is going to provide and streamline mechanisms to work with member states. And if you develop a prepared health systems, we can have the confidence that it can tackle any kind of emergencies, whether it's an anthropogenic or whether it's natural, or it can be something unknown at this stage.
Thank you very much, Sohail. And Dr. Mayala, at the country level, is DRC looking at categorizing or differentiating between shocks that the country has experienced?
At this time, I can say that at the Ministry of Health level, we're aware that the country or the different provinces are at different levels of development. And this is very important to take in account, and when we design the plan of interventions and when we design our project to implement through our implementing partners. We have a kind of 3 categories of provinces, saying that we have some provinces that are the really basic level where they need to provide, I can say, global technical assistance to let them to be improved in the scale of the development. And we have an intermediate level for some other provinces that need to fill some specific gap and where partners should to work in a complementary way. So some provinces are really aware to be at the head of the system, like which one I mentioned recently, located in a certain eastern of the country. And they are aware of their position, the resource they have, how they can mobilize the domestic resource to make sure that they, from their own capacity, they can respond to the basic needs and to have a complementary action from the different donors. So this is globally how the country is working depending on the different levels of development.
Thank you very much, Dr. Mayala. As we come to the end of this session, I would just like to take a moment to reflect on some of the points that have been mentioned. You know, we hypothesize that investing to develop a stronger health system will create the ability for that health system to absorb, respond, and recover from shocks and inherently create resilience. But we've heard that even strong health systems may not be able to respond to certain shocks and may break under those shocks. We also heard Kelly mentioning earlier, and I relate to this from my quality improvement background, where Kelly was talking about the importance of constantly adapting and iterating and improving when we're looking at how to strengthen our health systems. And it's less important to focus on tools, but more important to focus on what we need to do and how. And then also what has come up during this session is the importance of linking with other sectors beyond the health sector. So looking at the educational sector, looking at WASH and others, agriculture, environment. So we need to keep those in mind when we're thinking about our programs as well. And also just to mention that, just highlighting the point about that it was raised that there's an absence of a link between trade and health systems and security. So making sure that we're looking at opportunities there as well. And then also making sure that there's assigned roles for improved coordination. So thank you again for your attention and for your questions, and I will end here